Hello, MedSurg students. In this PowerPoint presentation, I'm going to talk about lower and upper GI problems. The first condition I'm going to talk about is a very popular one because many people suffer from this condition. It's gastroesophageal reflux disease, shortened to GERD. Basically what happens, it occurs because the lower esophageal sphincter is weakened. And so there's a reflux of gastric contents up into the esophagus. And gastric contents are the fluid in the gastric area is corrosive. So it irritates the lower part of the esophagus. And it can, if you have this for many years, you can get what's called Barrett's esophagus, which can turn into cancer. So it needs to be treated right away. It shouldn't be ignored. People that are obese, have sleep apnea, or wear tight clothes are going to be at risk. People on certain medications like estrogen, or if you're pregnant, you might be at risk. People with sleep apnea, I already mentioned that, are going to be at risk. Some of the causes of GERD, you can remember from the mnemonic reflux, is probably me. So R stands for a relaxed or incompetent lower esophageal sphincter. I stands for increased gastric volume, like if you ate like a huge meal, probably shouldn't do that. P is for pyloric stenosis. You're going to learn a lot more about pyloric stenosis in pediatrics, but that is a cause of GERD. And a motility disorder. For some reason, some people, peristalsis doesn't move as quickly for some people. So that could be a cause. Some food causes you can remember, it's people who eat crap. No, just kidding. So C stands for coffee, cigarettes, and citrus. R stands for refined carbohydrates. A is for alcohol and acidic and spicy food. P is for peppermint, and pregnancy actually isn't a food, but it is a cause of GERD. So the common symptoms of GERD include heartburn after eating, okay? Usually up to 2 hours after eating. So it's relieved by antacids and sitting up. That's why we tell people to raise their head of the bed 6 to 8 inches, and we tell them not to go to bed until 2 hours after they've eaten. It's diagnosed via an EGD, which is an upper endoscopy. And the big thing about that is you have to make sure that they have a gag reflex after the procedure before you give them anything to eat or drink. It's going to be treated also with PPIs. Remember, those are given once a day before breakfast. Antacids, H2 antagonists, and prokinetics. Okay, so remember those medications. So patients usually report indigestion, also known as dyspepsia, commonly known as heartburn. Okay, and they may have regurgitation. Now, patients can think that they're having a heart attack when they have the reflux, so they'll get like radiating pain to their neck, jaw, and back. They could have burning sensation in the esophagus, and they can have pain on swallowing, and pain that worsens with their position, like straining and lying down flat. So they can develop a sour taste in their mouth. They can also have tooth erosion because of the acid coming up. So those are the common symptoms of GERD. So patient teaching would involve telling the patient they need to be NPO 2 hours to 3 hours before they go to bed. They need to be on a low-fat diet, raise the head of the bed 6 to 8 inches so they can put the put blocks under their bedposts. Don't wear tight clothing, no smoking, E2OH, or caffeine, or anything that triggers their GERD. A hiatal hernia is a hernia where part of the upper stomach slips through the diaphragm and there's a hernia there. And there's all kinds of types, but basically it's the same signs and symptoms of GERD. If they need to have surgery, it's called a fundoplication. And they basically look at the picture, they wrap a piece of the fundus around the esophagus. So post-operatively, you would keep the head of the bed up. They would need a soft diet for a week, no carbonated drinks because that would make them burp, and they need ambulation and no heavy lifting after that type of surgery. Now we're going to talk about peptic ulcer disease. And peptic ulcer disease can occur in the esophagus, the stomach, and the duodenum. The most causative agent is H. pylori that causes ulcers. And we're going to go into a little more depth on that. To prevent peptic ulcer disease, clients should be taught to limit alcohol, stop smoking, limit NSAIDs, limit caffeine, exercise, and reduce stress, which can all cause ulcers to form. So with the symptoms, patients are going to complain of burning, fatigue, heartburn, vomiting, bloating, burping. And there's kind of a difference between a gastric ulcer and a duodenal ulcer. So with gastric ulcers, the pain occurs 30 to 60 minutes after eating. Okay, they're going to be more malnourished because they do get pain after eating, so they don't like to eat. And they can also have hematemesis, which is throwing up the coffee ground or bright red blood. Duodenal ulcers have pain 1.5 to 3 hours after eating. They usually awake in the night. The pain is relieved by eating, so they're well nourished, and they can have melena, which is dark tarry stools. Okay, for a diagnosis, there are a couple of tests they will do. They'll do an H. pylori blood test. They can do an H. pylori stool test, and also a urea breath test for H. pylori. EGD, which is an upper endoscopy, it looks at the esophagus, the gastric area, and the duodenum to see where the ulcers are. And also, if the ulcers were bleeding, they could squirt, when they're doing an EGD, they can squirt a little epinephrine into the ulcer and stop it from bleeding. And remember, you have to check the gag reflex after somebody has that. Barium swallow could be done. And the big thing with barium is they're going to need laxatives after they take barium because you want them to expel the barium and not have a bowel obstruction. And CAT scan is another option as well. The treatment involves medications, so they could be put on PPIs, which are taken once a day, not PRN, antibiotics for the H. pylori, H2 blockers, they can be put on those. Bismuth, remember, that has aspirin in it, so you have to watch out for salicylate poisoning, and it turns the stool black. And then acids. Okay, so usually students know all the indications and contraindications with these meds. One of the complications of peptic ulcer disease is bleeding. So look for dark tarry stools, bright red blood in stools, abdominal bloating, hematemesis, tachycardia, tachypnea, and hypotension. Now those are signs of hypovolemic shock. Tachycardia is going to come first, then tachypnea, then hypotension. Patient will be complaining of thirst. They'll have a narrow pulse pressure, meaning the systolic and diastolic pressure are becoming closer together. Another complication is perforation. So the patient's going to complain of severe epigastric pain. Usually it radiates to the right shoulder. They'll have either hyperactive, so borborygmi, or hypoactive bowel sounds. They'll have a tender, board-like, rigid abdomen, and they will suffer from septic shock because the gastric contents are going to go into the abdominal cavity. So look for tachycardia first, then tachypnea, then low blood pressure, and possibly a fever. A complication of peptic ulcer disease could be pernicious anemia. That's deficiency of B12. So it happens because the gastric cells, the parietal cells, secrete intrinsic factor. When they are damaged, or they can no longer do that. So the patient is going to have signs and symptoms of anemia. The difference between like iron deficiency anemia and B12 anemia is they have neurological symptoms in pernicious anemia. For example, they have tingling in their hands and feet. They have cognitive difficulties. They can become weak, but they can have that too in iron deficiency anemia. So they're going to need B12 injections for the rest of their life. And pernicious anemia is the type of anemia that presents with glottitis, so a red, beefy tongue is another symptom of pernicious anemia. Some patients with ulcers are going to need a gastrectomy. And after a gastrectomy, one of the complications is dumping syndrome. This can also occur after bariatric surgery, which I'm talking about later in this presentation, so I'm just going to present it here. So it happens after they eat, and it's caused by a rapid shift of fluids in the abdomen, and also from eating high carbohydrate meals. And this fluid shift causes the gastric contents to empty very rapidly. That's why they call it dumping syndrome. So the patient is going to, after they eat, they'll have tachycardia, cramps, diarrhea, dizziness, diaphoresis, palpitations, and fatigue. It's quite uncomfortable for them. So to prevent dumping syndrome and also to teach the patient, you would teach them these key points. They need to withhold PO fluids during a meal. So they should have liquids either an hour before or an hour after a meal, not with a meal. Drink fluids between meals, not with meals. And it's caused by eating refined sugar, so they need to limit sweet drinks, so like sodas, etc., juice. Avoid milk products, avoid simple sugars and milk products. They should change their eating habits to eat 6 small meals a day, eat slowly, and chew well. They need to lie down after meals to slow their stomach emptying. And this is different than GERD, so don't get that confused. They need to be on a high protein because protein stays in your stomach longer. So it's a strategy, and so does fat. So it's a strategy to help food stay in your stomach longer. So high protein, high fat, low fiber, and low carb. Gastritis is inflammation of the stomach lining. And there's acute and chronic versions. There's also non-erosive, which is caused by H. pylori, and erosive, which is caused by like your NSAIDs, alcohol, radiation, smoking, too much caffeine. And the complication is gastric bleeding, like they could have a massive hemorrhage if they have chronic gastritis. They can also suffer, people with gastritis, from pernicious anemia. They have the same signs and symptoms as somebody with an ulcer, so you don't have to memorize a bunch of different things. Okay, let's talk about hernias. And when we talk about hernias, it results from a weakened abdominal muscle, and parts of the bowel can protrude through that weakened abdominal muscle. So they can be described as reducible, meaning you see a hernia, you palpate it, and it goes back in, okay? It pops back out when you stop palpating it. Or it could be irreducible, and that another term for that is incarcerated. It means you cannot push it in. You cannot put it back to place. That needs to be seen by a surgeon because they may be at risk for obstruction or bowel perforation. Okay. Risk factors include being a male, and especially with a male, you're worried about this indirect inguinal hernia. That can slip down into their scrotum. Older adults, because all your muscles get weak as you age. People with increased intra-abdominal pressure are going to be at risk as well. So this is obese people and people like pregnancy, okay? They're going to have increased intra-abdominal pressure, so they could be at risk. Incisional hernias can happen after surgery due to things like malnutrition because the wound doesn't heal properly, or from being obese, or maybe there's an infection in the surgical incision. So that's another way hernias can manifest. Now, a hernia can become strangulated, which means the blood supply is completely cut off to the bowel in that area, and it can become necrotic. So you got to jump on that quick because they're going to need surgery. The patient will have the strangulated hernia. They'll be tachycardic, have abdominal distension. This can result in a intestinal obstruction, so they could be vomiting, fecal odor, vomitus. Okay, so that's like a little clue. If somebody has fecal odor, vomitus, they may have an obstruction. They're going to have a fever, and this could result in necrosis, obstruction, or perforation. So you need to act on it quick. And students get strangulated hernia confused with irreducible. They're two separate things, okay? So make sure you know the difference between them. Okay, hernia treatment involves non-surgical and surgical. So for non-surgical, you would have patients wear a truss, and this is a picture of a truss that basically holds the hernia in place, like pushes it back in. Surgical, I love these patients because they were super easy. It's a fast operation. It's a fast recovery when I worked in the recovery room. But after, I would have to teach them no coughing or straining after they have that kind of surgery. But it was really easy to take care of them. Now, irritable bowel syndrome is a syndrome where the cause is really uncertain, meaning functionally there's nothing wrong with the bowel, but yet people that have it complain of cramping, abdominal pain, bloating, and they alternate periods of like constipation with diarrhea, and it can be quite uncomfortable. So dairy, caffeine, alcohol, stress, anxiety, and depression may have a factor in IBS, irritable bowel syndrome. So patients would be taught to limit these factors. Constipation, you would teach the patient to exercise, increase fluids 2-3 liters a day. Everybody should be eating 30 to 40 grams of fiber a day to add bulk to your diet. And then always try to move your bowels at the same time every day. And if some help is needed, we always go in bulk forming medications first, then a stool softener, then stimulant laxatives and enemas. There's also medication for IBS specific that increases fluid secretion in the intestine to promote motility, and it's called lubiprostone. Okay, if somebody has bouts of diarrhea, there are medications they can take. So loperamide is a medication you can take for diarrhea. Psyllium is bulk forming, and that can help with diarrhea in certain cases. Allosterone, that helps firm up the stool, so they can take that as well. Also, they should be taught to start eating whatever food is giving them the diarrhea if they know what it is. Okay, now we're going to talk about intestinal obstruction. And there's two basic types. There's a mechanical intestinal obstruction and a non-mechanical. And I'm going to talk about mechanical right now. A mechanical intestinal obstruction means something has actually caused the intestinal obstruction. And they're going to need surgery, and you need to be able to identify it fast so that their bowel doesn't perforate. So it can happen from postoperative adhesions. If you look at this picture, cancer, like colon cancer, a hernia, intersuspension, which you're going to learn about in pediatrics, and a volvus. That's when the bowel turns on itself. So all those kind of things can cause an acute intestinal obstruction. What happens with the intestinal obstruction is you have the obstruction and there's going to be no passage of stool or gas, and that's called obstipation, and that's going to be proximal to the obstruction. Then there's going to be increased contraction in the proximal part, and they're going to have borborygmi, so they're going to have high-pitched tinkling sound in one area of the abdomen, and below it they'll have hypoactive bowel sounds below the obstruction. That's how you know one of the signs of having an intestinal obstruction. Then what's going to happen in time, there's going to be dilation because the gas is increasing inside the bowel, and there'll be compression, and then necrosis, and then finally, if they do perf, they're going to get peritonitis. So for peritonitis, be looking for a high fever, high white count, rigid board-like abdomen, and they'll be guarding. The abdomen is going to be really tender. and then they'll get shock and die if you don't recognize it early. So it's really important to recognize the intestinal obstruction early. The other thing about intestinal obstructions, never, ever, ever give anybody a laxative that you think has an intestinal obstruction because they could perforate. Nursing care involved in peritonitis includes putting the patient in Fowler's or semi-Fowler's position. This helps with lung expansion, and it also helps to drain the peritoneal fluid down. They most likely will have an NG tube, whether it's pre-op or post-op, so you're going to monitor and maintain the NG tube, and you've had NG tube care before. Keep the patient NPO if you think they might have peritonitis until the surgeon can see them. And then they'll still be kept at NPO if they have peritonitis. Monitor for hypovolemia, monitor for septic shock, and fluid and electrolyte imbalances. That's also important to do. Okay, non-mechanical intestinal obstruction means there's an obstruction. Really what it's referring to is that there's no peristalsis. In other words, the bowel is intact. It doesn't have any deficits except it's not moving. There's no peristalsis. So this could happen after surgery due to a paralytic ileus. It could happen because hypokalemia can slow the bowel down. And then if there's an emboli in the mesenteric, like an emboli shoots there, they can have a non-mechanical intestinal obstruction, and peritonitis can also cause that. So with paralytic ileus, you will not have bowel sounds. And the way to get the bowels kind of moving, if they had surgery, is we encourage them to ambulate to promote flatus. Flatus is the gold standard that peristalsis has returned. So that's what flatus means. And everybody gets happy when patients fart after surgery. There are some differences in the assessment findings between a small bowel obstruction versus a large bowel obstruction. So for small bowel, the small bowel is mostly responsible for helping us absorb fluids and electrolytes. So there's going to be a severe fluid and electrolyte imbalance. In fact, people can sequester like 5 liters of fluid in their small bowel, which is going to give them a relative hypovolemic shock. So look for the tachycardia, the tachypnea, the low blood pressure, the narrow pulse pressure. They could have fecal smelling vomitus, that might be a clue, and projectile vomiting. They are going to have metabolic alkalosis, especially if they have an NG tube, because from the pylorus up, if they're like vomiting, they're losing acid, so their ABG will be metabolic alkalosis because of the loss of acid. They could have visible peristaltic waves in the upper abdominal cavity, and they can have epigastric and upper abdominal distension. Now, when we talk about the large bowel, they just have minor fluid and electrolyte imbalances. They're going to have metabolic acidosis, and they'll have lower abdominal distension, abdominal cramping, and that's going to be intermittent and infrequent vomiting. They may have diarrhea, or they may have ribbon stools if they have an impaction. So those are the differences between a small bowel and a large bowel obstruction. The labs you would expect or anticipate in a client with intestinal obstruction include a high H&H. That's due to hemoconcentration because they're dehydrated, as well as a high BUN and creatinine for the same reasons. If somebody had a strangulated hernia or if they had a perforation, you might see an increased WBC. They could be developing peritonitis, so keep that in mind. Look for that board-like rigid abdomen. They will have decreased sodium, chloride, and potassium levels. Patients with intestinal obstructions need to be kept NPO, whether they're pre-op or post-op. You're going to put them in semi-Fowler's position because this helps drain peritoneal fluid. You're going to assess bowel sounds. You're going to probably, most likely, put in an NG tube for somebody with a mechanical intestinal obstruction. You may do it for somebody that has a paralytic ileus or a non-mechanical intestinal obstruction if they become nauseous and start vomiting. Manage pain, especially after surgery. Encourage ambulation after surgery because ambulation helps get the bowels moving again. And flatus indicates that peristalsis has returned. So there's been a resolution of the intestinal obstruction when it's non-mechanical if the patient has flatus. Okay, I'm going to talk about nasogastric tubes right now. It seems fitting. The nasogastric tube procedure and caring and assessing for placement and patency is on 4 different proctors. And the reason for that is that the nasogastric tube is a fairly common therapeutic procedure performed by nurses with the doctor's order. But it also has a lot of complications associated with it. So it's really important you know how to insert and remove and care for an NG tube. So this NG tube here is called a Salem stump. If you notice, it's got a blue pigtail. That's an air vent. And it's vented so that the end of the nasogastric tube doesn't get stuck on the gastric wall and start suctioning the gastric wall, okay? Because that could cause injury. So it's probably going to be called a vented tube on your proctor, and you may have to pick out what type of tube you're going to grab. So just remember the blue pigtail, and on top of that blue pigtail, there's a vent. Remember, blue goes to blue because that's a separate piece, and that was invented um, probably 20 years ago or so. But we didn't always have that, and it would leak if you didn't keep it above the waist. Okay, so always keep that pigtail above the waist. Don't infuse, don't irrigate through it, and don't clamp it. Okay, because you need that air vent to prevent injury to the gastric mucosa. Now, make sure you understand the reason your patient is getting a nasogastric tube. Are they going to be fed, or are they getting it for gastric and intestinal decompression? Okay, so that could be used for somebody with distension and intestinal obstruction. You want to assess the placement and patency. So first off, when you are going to put one in, you have to know how to measure it. So measure it from the tip of the nose to the ear to the xiphoid process. So put a piece of tape around the tube so you know when to stop when you put it in. When you put it in, remember the head has to go a little bit forward, not backwards, because you'll put it into the lungs if it goes backwards, if you put the head backwards. After you get it in, check the mouth because it could be coiled in the mouth, especially if it was really easy to place. You definitely have to get a chest x-ray to determine the placement. You can aspirate gastric fluid and it should be low, like a pH of 1 to 4, but the gold standard is always going to be a chest x-ray. All right, so you want to assess the patency and placement every time you're going to manipulate it, anytime you're going to irrigate it, okay? So to assess the placement after you get the chest x-ray, you're going to make sure you have the centimeters it's at documented so you can check and make sure it hasn't moved from that centimeter mark. So like in other words, it'll say nasogastric tube in left nair at 52 centimeters. So when you come on shift, you have to make sure it's 52 centimeters. You need to irrigate it with 30 mLs, normal saline, Q4 hours. Okay, document INO. Obviously, if your patient has needs it for decompression, it's going to be hooked up to intermittent suction. If they need it for tube feeds, they're not, you still can irrigate it. And some of the feeding pumps come with irrigation. And if they have a tube feed, you can probably use tap water. But with somebody that is having suction, it needs to be normal saline. You're going to put the patient in semi-followers. Make sure the tube is fastened to the gown, not the pillow, not the bed sheets. Oral care needs to be given every 2 hours, and you need to monitor the nairs to make sure they're not having skin breakdown. When you're going to remove the NG tube, make sure you check the order, obviously. You're going to wear gloves, explain the procedure to the patient, If they're getting fed, turn off the feeding pump and disconnect it from the tubing. Otherwise, you're going to have a huge mess on your hands. Flush the tube with 30 mLs of air to clear the tube of fluid before you remove it. Obviously, you're going to, if it's adhered to the nose, you're going to take the tape off so you're ready to go and remove it. So that's removing the anchoring device. Give the patient facial tissues and put a towel or a chalk across their chest. Have the patient take and hold a deep breath. That's when you're going to pull it out. Now, you need to kink or clamp the tubing when you pull it out in case there's any fluid left in it, because they'll aspirate that if you don't. Then throw it away, do hand hygiene, and allow the patient to perform mouth care. Stomatitis refers to inflammation of the oral cavity. And this can occur for many reasons, like, for example, after radiation treatment or after, having chemotherapy, because the cells in your mouth are quickly reproducing. The other reason people can get stomatitis is due to chronic kidney disease. So uremia can cause stomatitis. So if somebody has stomatitis, it's quite uncomfortable for patients. So you have to teach them to avoid spicy foods, salty foods, acidic foods, alcohol, and any type of tobacco products. They should eat cold, soft, bland foods and supplements that are high in calories. They need to use mouthwash without alcohol. Like, don't use those glycerin swabs because that has alcohol in it. You want to rinse the mouth with normal saline, room temperature tap water, or salt and soda water. In other words, hot drinks are not good, okay, for stomatitis. Floss gently and brush with a soft toothbrush, or use that those foam swabs. Rinse the mouth before and after meals to help them work up an appetite, and use coating agents, topical anesthetics, like we used to give swish and swallow lidocaine jelly, or oral and parenteral analgesics, because it is very uncomfortable. So some good examples of food to eat include like mashed potatoes, scrambled eggs, cooked cereal, ice cream, bananas, so soft foods. Now we're going to talk about inflammatory bowel diseases, and the first one is appendicitis. Depending where you are in peds, if you haven't had this yet, this will be new to you, but it's taught in pediatrics and in adult med-surg. So appendicitis is inflammation of the appendix. It could be like a hard piece of stool got lodged in there and causes inflammation. It could happen for no reason. Okay, so there's intense pain in the umbilicus, and it radiates the right lower quadrant. And I'm going to show you a picture of this on the next slide because you need to know McBurney's point. They're going to have a fever. They're going to have rebound tenderness, meaning when the doctor does a deep palpation, because remember, nurses only do light palpation, and they lift up on the palpation, then they feel pain. That's rebound tenderness. They'll have a fever, increased WBC. Don't ever use heating pads. Just in general, like anything with heat, that electric is not a good thing, but especially with appendicitis because the appendix could burst, okay? And if the pain is relieved suddenly and you didn't give pain medicine, it could mean that the appendix burst. And it's really important you catch this early, especially in young teens, because if their appendix bursts, it could make them sterile. The complication of appendicitis is peritonitis. So look for that board-like rigid abdomen, high WBC. They'll have abdominal tenderness with guarding, meaning they don't want you to touch their abdomen, right? They'll have distension and tachycardia. The red dot on this slide is where McBurney's point is, and this is a location on the abdomen, and it's used to diagnose appendicitis. It's a landmark. So it's approximately 1/3 distance from the anterior iliac spine to the umbilicus, and it's on the right side of the abdomen. So if your patient has tenderness at McBurney's point, it's highly likely that they have appendicitis. All right, we're going to discuss the difference between ulcerative colitis and Crohn's disease. They're both autoimmune diseases, but they have a little variance between the two. So with Crohn's disease, this affects the whole GI tract, okay? Mouth to anus, gut to butt, okay? It usually affects mostly the terminal ileum. So the ileum is the last segment of the small intestine where it hooks up to the cecum, which is the large intestines. Okay, whereas ulcerative colitis only affects the colon, the large colon only. Okay, so if you look at ulcerative colitis, colitis begins with a C. Just remember colon only. Okay, it happens typically in Jewish people with a family history, and for Crohn's, also smokers. Pain is in the right lower quadrant with Crohn's disease because it's typically in the terminal ileum, and they will have diarrhea, anorexia, and weight loss. Whereas with ulcerative colitis, since it's the large colon, the pain is typically in the left lower quadrant. And they will have bloody stools. It has a distinct smell. I mean, it brings back memories just talking about this. And the stools are often, they're bloody, but it's this kind of like maroon color, okay? And they have, like, it's frequent, like it's all day long for them when they're having an exacerbation. Okay? Treatment, typically surgeons don't like to operate on people with Crohn's disease. And the reason is, say they take out a piece of bowel. The bowel can keep having more injury to it. So they don't like taking out pieces of bowel in Crohn's disease because pretty soon they may be left with no bowel because it's from, remember, it's from mouth to anus. Okay. Um, Typically, they're going to be on corticosteroids and immunosuppressant drugs. With ulcerative colitis, they can be cured with surgery. So the surgeon would do loop ileostomy, which means they intend of hooking it up. They make this little pouch in the rectum called the J pouch. And so the patient goes home with a colostomy or ileostomy, sorry, and at some point it's hooked back up to the J pouch the surgeon has made in the rectum. Okay, and that's really important to know because people with ulcerative colitis can end up with colon cancer. So surgeons are usually eager to take that colon out. The diet for both ulcerative colitis and Crohn's disease includes low fiber, okay, because they have diarrhea, high protein because they need to heal, and fluids because they could be dehydrated with all the diarrhea. The complications in Crohn's disease often involve a fistula, okay, whereas with ulcerative colitis, it involves having a hemorrhage. The anticipated laboratory results for Crohn's and ulcerative colitis are very similar, right? They're going to have low H&H. They're going to have increased inflammatory markers such as the ESR, the white blood count, and that's C-reactive protein, is the CRP. Low albumin level. Now, I don't know if we talked about this, but when patients have a low albumin level, they are going to not heal as well or as fast as they could, okay? So that's one of the things we used to look at preoperatively for patients that were going to have like big surgeries, I should say longer than 3 hours, surgeries, is their albumin level, because if the albumin level is low before surgery, they're more likely to have respiratory complications. Fecal occult blood testing is going to be positive. Potassium, magnesium is going to be low in both. And then with ulcerative colitis, they're also going to have low sodium and chloride because your large colon helps you reabsorb sodium and chloride. So that's why it's low for that. And then for Crohn's disease, since it is mouth to anus, remember if they have irritation in their stomach, they are going to be low on B12 and folic acid, and they may have to take injections if their parietal cells are no longer secreting intrinsic factor. And then anti-glycan antibodies are a biomarker for both MS and Crohn's disease. The next inflammatory condition we're going to talk about is diverticulitis. And you can't have diverticulitis without diverticulosis. So I'm going to talk about diverticulosis first. Diverticulosis means that the colon has these outpouchings. And as you age, you get more of these outpouches. And it's normal to have them as you age because, as you know, your muscles get weaker as you age. But diverticulitis occurs when the outpouchings become inflamed. They get inflammatory and it causes tenderness in the abdominal cavity. So with diverticulitis, you can expect a fever because it's inflammation of the outpouchings. Pain is going to be in the left lower quadrant. Patient needs to be kept NPO. They'll get IV fluids, possibly an NG tube. They'll be given pain medications, opioids, so watch them for constipation. Absolutely no laxatives, and avoid seeds and ingestible material like nuts, popcorn, because they can get stuck in the outpouchings and cause inflammation. All right, we're going to talk about bariatric surgery. I had the privilege of working in a bariatric surgery center of excellence, and it was an awesome experience. When I worked in the PACU, I got to take care of bariatric patients when they came out of surgery. But also, when I became a nurse manager of peri-anesthesia, I also saw them on the pre-op side. So what you need to know is there's two kind of camps of bariatric surgery. They can have restrictive surgery or they can have malabsorption surgery. And I'm going to talk about both of them. Okay. So to qualify for bariatric surgery, you have to have a BMI greater than 40 or a BMI greater than 35 with one comorbidity. For example, like diabetes type 2. Okay. So with restrictive surgery, the patient, for example, can have a lapped adjustable gastric band or a vertical banded gastroplasty, again, vertical sleeve. So in other words, these surgeries restrict the amount of food that can go into the stomach. So that's how that works. When we talk about malabsorption surgeries, this is your Roux-en-Y, otherwise known as a gastric bypass. So after they have whichever type of surgery, they're going to be at risk for nutritional deficiencies because they're not going to be eating as much. So those with the malabsorption surgeries are going to need B12, calcium, folic acid, and they quite possibly could need the B12 in injections. One of the reasons I really enjoyed working with bariatric patients is because I knew this surgery was going to change their life drastically. Like I saw people come in and they were on all these hypertensive medications, all these diabetic medications, and by day 3 after their bariatric surgery, they were off, they went home on no medications. It was just like a miracle to me. But this surgery has a high percentage of patients that get DVT, so they're going to have SEDs on before surgery. And actually, in the PACU, I used to give 5,000 of heparin, 5,000 units of heparin SC, which is, you don't usually do that after surgery, but we did it for bariatric surgery. So after the surgery, the complications, another complication is anastomic leak, and this could cause the patient to die, so listen up, okay? They're going to complain of shoulder and back pain. They'll have tachycardia, restlessness, so that's going to tip you off that something's wrong, and oliguria. Oliguria means low urine output, so call the provider immediately because the patient needs to go back to the OR. PO fluids postoperatively, they start out very small, 30 mLs at a time, 120 mLs per day times 2 days before they do anything else. And they are going to be prone to dumping syndrome, which I talked about earlier in this presentation, so review the implications of dumping syndrome. The type of ostomy surgeries I'm going to present to you include colostomy, ileostomy, and urostomy. And the reason I'm including urostomy here, it's just for ease, even though it refers to urine and not the bowel. But these, I think, are the most tested on proctors. That's why I'm going to go over it. Now, remember, look at how good this stoma looks. It's shiny, red, wet, and protruding. So it's a round shape. And it should be 3/4 of an inch protruding. An ileostomy is an ostomy of the small intestines. It'll be located in the right lower quadrant. The stool output is going to be very high, up to 2,000 mLs per day, so your patient will be at risk for dehydration. The output initially is going to be really dark green, loose, and it's odorless, so that's at least a benefit. The stool consistency will gradually thicken over time, but it's always going to be it's not going to be formed, okay? You need to empty it frequently, the appliance, when it gets 1/3 to 1/2 full, and you'll be doing that several times a day. So for a colostomy, there's 4 general areas where a colostomy can be placed. So the ascending colon, it's placed in the right lower quadrant, and the stool consistency is liquid to semi-solid stool. Transverse is on the transverse colon, and the consistency is liquid to semi-formed. And then descending and sigmoid colostomies are, the descending is semi-formed stool and sigmoid is formed. You need to empty the appliance or teach the patient to empty the appliance, the colostomy appliance, when it's 1/3 to 1/2 full. Now, the ascending colon, the right sided output is going to be irritating. It's very close to where an ileostomy would be, and that's a small intestine ostomy, and that's also very irritating. So stool from that area is still very irritating to the skin, so you have to watch for that. ATI loves to show pictures of these on the proctor and ask you to identify which type of colostomy they're showing you. This is the double-barreled transverse colostomy, which is a perennial favorite of ATI. With this type of colostomy, there are 2 stomas. There's a proximal stoma, and that drains stool, and a distal stoma that drains mucus. You have to remember that the colon is always producing mucus, and so that's why mucus is going to come out of the distal stoma. An ileoconduit is the most common type of urostomy. So a urostomy is a urinary diversion that allows urine to exit the body after removal of a diseased or damaged section of the urinary tract. Now, in an ileoconduit, the bladder is totally removed. And so the surgeon takes a little piece of the ileum, a loop of the ileum, and makes it into a conduit for urine, and then they hook the ureters up to the conduit, and then urine flows as it's made into like a appliance, okay? And you should expect mucus in that urine because the ileum is part of the bowel and it secretes mucus, and it still secretes mucus after it becomes a conduit. Stoma teaching involves teaching the client to inspect their stoma daily. And as a nurse, you would inspect stoma every shift. Stomas are free of nerve endings, so patients are not going to feel pressure if the patient touches their stoma, okay? Note the edema, and it should decrease over the next 2 months, which means they may have to change their appliance measurements slightly. Note the color. Teach patients it should be pink, shiny, and moist, and the stoma should protrude about 3/4 inch from the abdomen. Teach the patient that they need to call the provider if they start bleeding, and the opening of the appliance should be 1/16 to 1/8 inch larger than the stoma to prevent constriction. Teach them to report to the provider pale, dark red, purple, brown, or black stomas to the surgeon, and you would do the same as well post-operatively.